I want to introduce you to Professor James Tomby, who is in biochemistry and nutritional sciences, and he is the reason they're here, and he's the reason we've got so many good projects going in Uganda. And I'm sure you all know James, who is quite famous. Not only of course, he's the department chair of nutritional sciences, but he's won many awards, Distinguished Nutrition and Education Award, presented by the President of the United States, wasn't it?
No. I wish.
Almost. Vice President.
No, not close.
Okay. Anyway,
Just make sure.
Right. Anyway, so rather than do an inadequate introduction myself, I'm going to let James introduce his distinguished colleagues.
Okay. So it's Christine. Is she? She's coming. Okay. So be right just a second. Okay. So Christine is still outside.
Okay.
Just want to make sure you're all together.
Do you want to make a comment about our relationship with
Yeah.
the work in Uganda in general?
In general?
Yeah.
Yeah. Okay.
For orientation.
Yeah. So basically, the relationship between the University of Wisconsin-Madison and Mukono University, I think, is more than 50 years old. I mean, there are a lot of people who started this relationship more than 50 years ago. But recently we have been doing a lot of educational programs, study abroad programs with John Philip, as most of you know. This program has been running for almost 15 years now. And then recently we have been doing the global health, which is part of the global health certificate through the Global Health Institute that John heads, John and his colleagues head. And we do the global health certificate during the summer period, whereas the study abroad is during the fall and winter time. So when we go to Uganda, sometimes through the Mukono University, Kampala, we tend to work in communities in Uganda. That's where the global health issues are. And over there within the communities, we have people we work with, we have colleagues we work with. So for the global, for the mobile clinic program, for instance, we work with Dr. Konde, and we work with Jamir Kakembo, who is the chair now. I'm going to maybe start the introduction. So we are very happy this evening to have the three colleagues from Uganda. And they have been here for about a week. We work with them. So one thought I had, since we have been collaborating with Mukono University for quite some time, and most of the people who have actually been coming to Wisconsin, just like we do take people to Uganda, so like some kind of exchange, faculty and students, has always been with the university campus, people who will stop there. So this time we thought that the people we work with in communities in Uganda will also have an opportunity to come here and see the kind of programs or projects or what we do here in Madison. So they have been interested in various community services in the city of Madison. So the first one is Dr. Anthony Konde. Dr. Anthony Konde is the principal medical officer of Mukono Municipality. So they will probably tell you about how the administrative structure. So they have municipalities. So the town of Mukono, which some of you have visited, is a municipality. So he's in charge of all the health services or issues in that municipality. So Mr. Jamir Kakembo is the administrator of the division in which Mukono town is located. So he oversees the administrative structures, including services like garbage collection all the way to transportation issues, just like in the city of Madison is governed. And then Christine Namuli, who is right in the middle there, is responsible for the educational services within the division which Mr. Kakembo heads. So here you can see a connection between health, education, and the administrative structure. Because when we go out into developing countries to do our work, we have to make sure that the political, the organization is aware of what we are doing in their communities. So there's this wide representation, as you can see here. So what we decided to do is for them, because this was a short notice, just to give us an overview of some of the effects of urbanization on health in Uganda, since we have Dr. Konde. And what will happen here is that they are going to share with us some ideas, and they are all going to chip in periodically as the seminar progresses, depending on the knowledge they have. So the urbanization has created a lot of issues on health, and because we have been going there for many years, we have been noticing these changes, and they will outline these changes for us. So I would also like to, first of all, to thank you for agreeing to come here and share that information with us. And what we will do is, as we go through, we have about, I don't know, about 40 minutes. We will have time to ask questions and have some interactive conversations. So for those of you who are planning to go to Uganda, these are the individuals that you meet. So it is an opportunity for you to, at least by the time you go, you have some contact, and makes your programs much easier. So why don't we just get started? And I think Dr. Konde is, so maybe we can,
let us squeeze space.
You can squeeze space on the other side. Yeah. So if you are to use this, just do that. Okay. Oh, I think you can just follow this.
Arrows.
Are you going to do it?
Yeah, just use the arrows.
Okay, just
In the bottom right.
Okay. Yeah.
So, is it good afternoon? Good afternoon, everyone.
Afternoon.
Is it evening? So, thank you for welcoming us to Madison. What we are going to share with you is our experience with urbanization. We are coming from a municipality which is young, 3 years old. So we came to learn as leaders to see how we can also improve our systems and to serve our people better. So we chose this because health is encompassing everything we do. And to us as service providers, we've started seeing the challenges of urbanization. In Uganda, where we come from, majority of Ugandans don't stay in towns. They stay in the rural areas, but we are beginning to see a lot of them now coming to the towns. And Mukono is one of them, and we are seeing challenges. So, a brief about Mukono. In Uganda, we have 22 municipalities, and Mukono is one of them, an urban area. Our area is quite big, 210 kilometers, and you have a population of 150,000 people. The combination of that population, we have the rural communities. Not everyone in the urban council is urban, but we have people who are in the rural areas, peri-urban, and the urban, the center. And in terms of health service delivery, we have 5 public health facilities. Here I was told you have 3 hospitals, but we don't have a hospital in our municipality. And we have levels. We have 1 health center 4, 1 health center 3, and 3 health center 2s. Here, I don't think you have such levels, but in Uganda, administratively we have what we call decentralization. So even these levels of health service delivery follow that. We have our municipality as a county. The highest level of service delivery is the health center 4. So below a county, we have sub-counties. So our municipality is made up of 2 sub-counties. For the urban communities, we call them divisions, and here is one of the divisions. Then below the sub-county, we have administrative units we call parishes. We have 9 parishes, and ideally every parish would be having a health center too. But we have only 3, so we are not yet there. So the decentralization and this level of health service delivery came to make sure that at least people have some bit of health services within a radius of 5 kilometers within reach. But we have not reached all our parishes. These are some of the reasons we've observed that are motivating people to migrate from the rural communities to come to the urban areas. People are moving from the rural areas to come to urban areas because they are looking for opportunities for employment. Because in the urban areas we have some industries coming up, service, people in restaurants, schools, so there are opportunities and people tend to come. They are looking for better health care. But as I'm going to show you, the health care they are looking for is challenged. There is better housing and also electricity. In Uganda, not everyone has the privilege to have electricity. So we have electricity mainly in the town centers. So people migrate because we have better housing and also electricity. Quality of education is also another factor. We have better schools in the urban areas than in the rural areas. So people now, if you want your child to have better education, you tend to look for better schools in the urban areas. The other is attraction to entertainment and leisure. In the urban areas, we have a lot of leisure. Some of you will come to Mukono next time. Maybe we shall be able to show you some of these and you appreciate. Of course, in the urban areas, people have cleaner and safe water. But you still will have a challenge. Someone did a study. I was telling Professor that maybe we should redo the study and find out. But at least you have more access to water if you are in the urban area than in the rural area. Even in the urban area, people buy water in some places, but it is affordable and you can easily access water than in the rural communities. So these are some of the reasons why people come to the urban areas. Now, since we are discussing urbanization and health, in Mukono, this is our health center 4 as the highest level of service delivery. And some of the services we offer, we have a mental health, maternal and child health, geriatrics, eye care, outpatient, inpatient service, comprehensive HIV care, safe male circumcision, and as a country and the Mukono community, we are appreciative to the American people. I don't know if you can recognize this. It is not very clear. I don't know. Some of you. This is PEPFAR. And I don't know if you recognize this. So some of our programs, especially the HIV component, we've been getting a lot of support from PEPFAR to to support our activities. And what is this? I think this is a research organization for the U.S. Army. Together with this organization and the Makerere University, they have a program they call Makerere University Water Aid Project, and they get funding from PEPFAR. So we are working with them to support our HIV program. So of course,
PEPFAR stands for
PEPFAR.
President's Emergency Funds for AIDS Relief.
Exactly.
Yes.
Big one.
And this is the Uganda, so that collaboration helps us to deliver some of our services. Because in Uganda, funding for our health care system comes from government of Uganda and partners mainly. So, one of the things we've seen is overstretching of our healthcare system. The health center I showed you is our highest level of service delivery in the municipality. And for the period between July to December 2013, we saw 23,430 patients in our outpatient department. And our outpatient department works Monday to Friday. Over the weekends, we may receive emergencies, but Monday to Friday, they are our major days of working. And this gives us around 195 patients seen every day. And we have 3 clinicians in the outpatient department. And you can imagine, some days someone seeing 65 patients. Definitely this compromises the quality of care. You don't have enough time for your patients. And it is because more people are coming, and yet there is a lot of pressure on the system. Our drug budget for a year is 56 million Uganda shillings. This is equivalent of around 22,400 US dollars. And the more patients we get, the more we can't give them the drugs. So what normally happens is that, yes, someone may come and a clinician will give you a prescription. Then you go to buy. Some of our patients are quite poor and they end up at times going back to sit at home, or they try alternative, we call it alternative medicine, using herbs, and some go for prayers. And to us as service providers, this is a big challenge. And even our health workers, they are overworked. In fact, some of our health workers quit because of some of these challenges, and they look for alternatives anywhere. And to us, we feel this is an effect of what? Urbanization, overstretching the limited resources we have. In Uganda, most of the payment, people pay out of pocket. We don't have a developed medical insurance scheme. And that's why we have so many people coming for the free services which government is providing. But even those services are inadequate to meet their needs. Another example, we prioritize maternal and child health. In Uganda, we are among the countries where we still have very high maternal mortality rates of around 438 mothers dying per 100,000. So we've been having programs and campaigns, even through our leaders, to tell our pregnant women to come for services because we don't want them to die. And they are responding. But when they come, we have these challenges. So for the same period, July to December 2013, we saw 9,630 pregnant mothers coming to attend antenatal services. And we conducted 2,499 deliveries. and we didn't lose any of those. But when you go to the human resource, our maternity unit has 8 midwives. So at times you find they have to do antenatal, they have to do the deliveries, and it is quite a big challenge. So when you compare those numbers, at least 8 moms are seen in antenatal clinic every day. And we conduct an average of 13 deliveries daily. However, our maternity ward has 10 beds. So the implication is that these mothers cannot spend 24 hours with us because someone is competing, waiting for that bed. And it is a big challenge. So you find that we tend to discharge our mothers a little early. And at times we may not happen what happens when they go home, because we don't have like social workers to follow them when they go back home. However, what we've done, we normally give them the phone contacts of the midwives, and we have, through some of the partnership, we have got a toll-free number which they can call in case they have a problem. And the other challenge in Uganda, we also have high rates of teenage pregnancies. Also making this number go up. Some of these teen girls come to town because they are looking for employment. In Uganda, we have a challenge that the girl child has less opportunities for education than the boy. So some of them still come to towns looking for employment and they end up getting pregnant. So these challenges are coming up more because of urbanization, partly. This is an example. Excuse me.
Just one question, Anthony.
Okay.
You're talking about these pregnant women coming in and what the rates of mortality are, and I'm wondering, at least they get to a health facility. Do you have any idea how many women are delivering outside of the healthcare system, delivering at home, and don't even get to a healthcare facility? Is that a large number?
Yes. In the urban area, we have around 70% coming to deliver, and 30% delivering from different areas. But in the rural areas, I think it is 40% delivering in health facilities and around 60% delivering from home. So this is an example of a clinic, antenatal clinic. So you can see the crowding. These women came to attend antenatal. And you can see we have this construction going on. Initially we had a waiting area. Okay, you can't sit clearly here, which could accommodate around 20 mothers a day. But now they come around 80. So the place became very small for them. So one of the interventions we are doing is to make sure we have almost completed this construction, to make sure we give them more space so that when they come, at least they can sit comfortably as they wait to be attended to. But you can see the numbers. Because they have to wait, because the health workers are few. This is an example. This is how our ward is. I think those who are midwives or doctors, you quite know that maybe you need a ward where mothers will come and wait, first stage, second stage, but we have one ward for every mother, and it is 10 beds. In fact, inside here there are 8, we have 2 in the side rooms, and normally the 2, we reserve them for those mothers who have had a cesarean section. So this is our ward where they compete for the beds. And this is where we deliver them from. We have 2 beds. The other one is inside that curtain. So this is the infrastructure we have that is getting overstretched because more people are coming to consume the services. And because we are public service providers, we don't chase away people that you should not come to attend to our clinic because it is public. So that's why people will keep coming in and you can't chase them away and maybe go to another unit or people will just come in. The teenage pregnancy, you can see this young girl. This girl got pregnant when she was 13 years and she's an orphan. Here, it is when she had delivered. We did a cesarean section on her. Her mother is HIV positive. The father died. And she was living with an auntie who was also HIV positive. So, in fact, they wanted to carry out an abortion on her. And in Uganda, abortion is illegal. So, it couldn't happen. And looking at her size, she had more risks of dying while you're carrying out an abortion than keeping the baby up to term. So we've got some well-wishers who are helping her to grow up and also to look after the baby, because the man who made her pregnant was an uncle. And in Uganda, if it was a case of defilement, at least we got social worker who followed up this case, and the man is in prison, is in jail. So we have such cases happening. Now the challenge is, who is going to educate this? This baby now is around 2.5 years. But now, educating this boy, he's a boy. So these are some of the community challenges coming up because of urbanization still. Because they came to town because at least in town you can easily get something to eat, and in the end they get these problems. Urbanization is also associated with high rates, high prevalence of HIV. Our prevalence in Mukono from the clients we screen is around 9%, compared to the other parts of Mukono as a district, which are rural, and they have an average of around 4%. And in the urban areas, we are getting a lot of prostitutes coming because people are looking for money. Prostitution is high in urban areas, and these people, they are part of the people we call high-risk groups, most at-risk populations. But they come for entertainment, for leisure and whatever, and they are a source of this high. Entertainment, drug abuse and substance abuse is high in the urban areas and also contributes to this. Peer influence and pressure, working far from home. In Uganda and in our municipality, we have the highway going from Uganda, going to Kenya, going to Rwanda. It passes through Mukono. So we tend to have these long distance truck drivers also parking within our vicinity. And when they stay, they also promote prostitution because they normally are looking for women. We have our neighborhood, some fishermen. In the fishing communities in Uganda, you have less women in the fishing in those islands, and we have more men. So the men normally, they are, majority of them, they are illiterate, but they get money from the fish. And when they get the money, they will come to the town for entertainment and leisure. And they also promote prostitution, and those are some of the issues promoting the high HIV prevalence. And this picture here, I think, is not very clear. But one of the things we do, we go to some of our communities and carry out sensitization on HIV, and we also conduct testing so that people know their status. Because in Uganda, our emphasis is on prevention because it is cheaper. And the first intervention in prevention is to know your status. So we encourage more people to come and test. So this is one of the outreaches. And I think some of the students who came last year, we also provided an outreach like this for the community, for the outreach, so that people come to know their sero status. So these are some of the activities we do, but we don't do them routinely because at times we don't have the resources. But the demand is still high. We have not reached everyone to know HIV status. Of course, the other challenge which comes with HIV is orphanhood. This family lives in Mukono. This HIV orphanhood, okay. They are staying with a grandmother who is also HIV positive. Their parents died because of HIV. And as you look at them, I didn't put there the house in which they are staying, but you can, this is the wall. It is we call it mud and water house. So these are potential street kids now coming up within our urban area, because they have to look for survival. You cannot believe some of these ones would be going to school, but occasionally they don't go because they don't have support. You can look at how they are. And we went to visit them. Someone spotted them and alerted us, but we've not yet got people to sponsor them. There is a big girl who is not in this picture. She's, I think, around 13 years. She dropped out of primary 7 last year. However, this year we've got someone who is going to pay fees so that she goes back to school to minimize this and also not to become pregnant. But you will find these ones go to fetch water for people so that they can get some little money to get food. And these are some of the challenges. Ideally, they would have been staying in the villages, but of course, they come to town because they can easily maybe get a few shillings for doing pet work. The other health challenges we've been noticing is maintenance of sanitation and hygiene. It's a challenge. We are beginning also to see more slum dwellers coming up because people, our planning, all the physical planning, is a bit challenging that I think the rate at which people are coming is not at the rate at which we are doing physical planning. And in Uganda, we don't have like housing schemes. People will tend to construct their own houses. So we get those challenges. In the evening, along the roads of Mukono, you will find many people selling food vending. Under public health, this is not safe food, but because it is a cheaper option for people, the low income earners, the slum dwellers, to get something to eat, you will find them coming to sell food. Today we've seen somewhere, at least they have vans, which are very hygienic and producing food. But I didn't get a photo of this, but it is also something coming up as a problem because people are not eating safe food. We have increased accidents as a challenge. I will show you part of what is causing these accidents as a challenge. Our roads are narrow, and like in evening time, you will find very many people walking competing with the cars, pedestrians, and the motorcycles, and in the end they get injured. And we are also along the highway where there is a lot of traffic. We are also beginning to see non-communicable diseases, diabetes, hypertension, etc., which we never used to see. With urbanization, of course, we have more people sitting in offices, doing less activities. Our eating habits are also changing. And in our clinics, we are beginning to see more of these cases coming up. Of course, it is quite a bit of a challenge. You saw the budget we have, and the Ugandan government, we are mandated to provide what we call a minimum health care package. The minimum health care package, you find that people who are diabetic, hypertensive, they are not catered for, because priority will be going to diseases which happen, which we see more, like malaria. If we see diarrheal diseases, we are prioritizing childhood illnesses, like conducting immunization, maternal health. So these people are beginning to come, but our system, they are a bit disadvantaged. So this is an example of some of the sanitation and hygiene challenges. We used to have very little garbage, but over the years, we are getting a lot more garbage. And the municipality has some of these skips, but they are now becoming fewer than the population we are serving. And you will find people dumping crudely. This is a challenge because the resources we have one truck which can empty this, and yet the area is too big. And as a local government where we serve, we don't have money or enough resources to buy the garbage trucks. We depend on the national government to provide this. But previously, when the population was a bit small, this one would not happen, because these ones you could put them there and you empty them once a week. But now we find that almost after 2 days, you need to come and empty. This is another example of some of these people. The slums coming up. And the other bit of it, that some of this, the land, tenure system is private. People own their own land. And you come the following day, someone makes a makeshift house to sleep. And in the morning, they walk to go to look for something to do. And this is a challenge. We have not yet done physical planning for all these areas, because the area is too big and the resources are not sufficient. And you can't chase away these people.
Do they have plumbing? Do those houses have plumbing or electricity?
Yes, some of these have, but okay, I didn't. Okay, I had other pictures, but for example, these ones use pit latrines. They don't use the flush toilets. Like this one doesn't have electricity, but some of them have. In fact, this one had a small generator around there. Yeah. One of our transport means is using these motorcycles. This is a stage, I don't know, like a bus stop, where someone will come You negotiate with the owner, the rider, how much is going to charge you to take you where you're going. And you end up competing. Our roads are not wide as here. You have one road having traffic going in opposite directions, and you compete with these riders. And peak hours, there are too many. Like evening time, you will find them too many because people are going back home. And we've had a lot of accidents, either these people knocking people or being knocked. And accidents also constrain our healthcare system because we don't have enough resources. And even individuals, because if you got a fractured femur bone, ideally you would need an operation. And majority of the people may not afford an operation. So you end up on traction, spending longer periods in the hospital, and you are not earning. And they are very common. Fractures are very common with this type of transport. The other means of transport, I did not put it here, but this is a common cause of what? Accidents. So, having showed you some of our experience, we thought we could discuss, for example, how has Madison overcome or coped with the effects of urbanization on health. We don't know if what we are going through was once a challenge here or it is still a challenge. How are you managing? Is urbanization an issue here? We don't know. We came to share experiences. Then how can Madison work with Mukono to address some of our health challenges? We came to Madison, we are mainly working with the university and the students. James told you about some of the programs. In Mukono, for example, there is a school where they are trying to use biogas, which is promoting a safe environment. But we have a lot of the other garbage. And we have like projects. The other third bullet, are there students interested in undertaking research in Mukono in relation to our health challenges? You've seen some of them. So students are welcome to do projects in Uganda. Because global health, I think we are one globe. So you can also participate in maybe undertaking studies to compare with what is happening here. And maybe last, any other issues we can discuss. So thank you very much. That is what we wanted to share with you under global health, what is happening elsewhere. Thank you very much. So I don't know who is the chair.
Well, maybe at this point, Jamil and Christine can also chip in and briefly sort of summarize the education and the administrative structure and see how those fit into this health, how those fit into health. And then, of course, general discussion from the audience, as Dr. Konde has requested, to see whether there are some challenges that you see here in Madison that compared to what's going on.
Thank you very much, Professor. I'm Christine. Those who have just come in, I'm Christine Namuli Kigongo, in charge of education in Mukono Central Division. One of the challenges we have that contributes to the health problem is the dropping out of school, the girl child drop out of school. Okay? At primary level, our girls and boys are examined at primary 7. So many of them do not continue, just because of the belief we have in Africa, and particularly in Mukono, our division, that some parents due to the mega limited resources they have, they prefer educating more the boys. So at that level, E7 level, primary level, they feel that that is enough for a guy, and the rest is preparing them for marriage. So at that rate, girls drop out, doing nothing, and as a result, they get early pregnancies, which we saw that it is also a problem health-wise. As they go to deliver, they can't manage the bills and the rest, as the doctors think about it. We also find other problems with the families, which can't, they raise up, they have so many children, and they can't afford the education sector. The education services they can't afford, they have to look for food and the rest. So we find that many of, again, the boys, some of them can't go to school because they don't have other facilities, like in Uganda schools, we have to put on a uniform, which I think is different here. If you don't have a uniform and other requirements, you can't be in school, so you are chased away as a result, and the parents can't raise money. Though we have UPE at primary level, universal primary education, we have that system. It is free of charge, but there are those other requirements which come by. So parents complain that that is a free education. We can't even buy the books, we can't afford the uniform, we can't even provide for the meals. So you find children going to school, they maybe say they took porridge for supper, and they are going to school without any meal up to 4:30 in the evening. Do you think they can concentrate in class? So they look for other means. They chase themselves out of school because of that. The parents can't afford to pack food for them. The school cannot afford because of the mega resources, because of UPE in rural areas. That's why most of them come to the urban areas to find other petty jobs, and they become a problem. They become petty thieves for the boys, petty thieves, so that they can earn out a living, which also causes a health problem in town. I think that's all I can add. Thank you.
Thank you so much, Professor. I'm very much delighted for having this chance to speak before this calm class. People who are ready to learn from and understand issues that are taking place within Uganda. But I'm wondering, my friends who is soon going to Ghana, can you come and sit here? There is a seat around here. Mine is more administrative. You were told, I'm called Kakembo Jamiru. I'm the chairperson of Mukono Central Division. That means you can call me mayor of the division. So I have a council of 26 councillors. We sit, that council always sits once in 2 months to deliberate on issues like I showed you. And we have a budget of a council. So that budget is supposed to cater for many of those issues that have been identified by Mr. Konde. We talk about, we have a budget for garbage, we have a budget to work on our roads, we have a budget for schools, construction, we have a budget for constructing public toilets, and so many other issues that we handle as a division. So my section is, for the councillors, we are 26, I'm the 27th, and I have an executive which sits once every month. That executive is comprised of they are councillors, but when I elect them to join my executive, they become secretaries. They are my secretaries. And we have the other section of technocrats. That is the town clerk and his administration. Those are government workers. They are paid salaries from government and other issues. They are the people handling money. Ours is policy issue. When we tell them that, please, want to do this, they look for the money and do it. But what he has been saying is what is alarming. Actually, we want to iron out all those problems, and we don't want them in Mukono. But the issue is, do we have the finances? If I can tell you about how we get money. Our money is that we use to do our work mostly comes from local revenue. When I talk about local revenue, those are the funds that are locally raised from the communities. For example, somebody has a shop, we go in, we get some money from him or her for a whole year. Now, that money is used in many things. And you can find that we cannot manage to clear all our burdens using that money. And we have some, for example, when we collect 100% local revenue, we divide it and we share with the municipality because ours is in a triangular form. If I could have a pen here and show you. Ours is our administration is in a triangular form. It's like this. This is the municipality up here. This is the division which I head. It's called Mukono Central Division. And there's another division here called Goma Division. Now, Goma Division also has a chairperson. Now, when we get funds, for example, when we get 100% of the money collected from, for example, local revenue, it might be licenses, permits, oil, plans, and much more. We divide it. We give 50% of this money, 50% of this money to the municipality. Because we have a book called the Local Government Act. That is the act in which we operate. It's the law which governs local councils in Uganda. And it stipulates that when you get money, you divide it into percentages. We give the municipal council 50%. There, we remain with the 50% to do all those cores that you have seen and more that you have not seen. As I have told you, roads, schools, and much more. Now, from this manner again, the law tells us to give back to the villages. For example, you people have ever come to Ruweza village. That is one of my villages. Because I have 41 villages within Mukono Central Division, of which I govern. Now, I have to give 25% out of this 50% to the village, to the local council one, to work on, for example, their spring wells. They can be having a problem there. We are encouraging them to plant some trees, etc. Now, the law tells us to give them 25% of this. Of course, we make it 100%. But of course, it doesn't increase the money, it just decreases it. Now, from this, then we have what we call the parish or the wards. The wards. Those are governed by the LC2 chairpersons. And we give them 10% of this money that we have remained with. 10% has to go to wards. Now, you find we have problems. In most cases, we remain with around 15% to do all that work. Now, this is supplemented quarterly by some money from the center, which is also not enough. And you find problems. People are yearning for services. For example, they elect you because they are sure that you are the person who is going to deliver. Now you reach there where they think there is a lot of money, you fail to deliver. For example, collecting garbage and taking it to the landfill. There's a place called Katikolo where our landfill is. You fail to deliver. The roads are not worked on properly. You don't construct public toilets. You don't go and construct schools or school quarters for the teachers. Now, people turning against you because they think you are failing to deliver. Yet you have the money and you are putting that money in your stomach. You combine with your staff, you combine with the technocrats and eat that money. Those are some of the issues that raise. But of course, there are things that we have done and quite successfully. Because we can't be there with, though a small budget like it is, and we fail to do anything. We have at least done something. For example, if it is contributing to our health section, we do give them some money, little money, but of course it is not enough. If it is constructing roads, that's why you find when you come to Mukono, there are some Maram roads. Actually, maybe some of you have never seen Maram roads, but there are Maram roads. How can you understand Maram roads? They are not tarmac.
Gravel road.
Gravel road.
Okay, gravel roads. You get me? So, we do construct gravel roads at some extent. At times, we maintain gravel roads. We have gone and maybe put up some boreholes, some spring wells, though many of them are disturbed by their water tables because they are a bit contaminated. But now National Water is helping us by extending services to rural areas so that those people can also access that water. But it is also expensive because a jerrycan of 20 liters at times costs 200 shillings or 100 shillings, which is not all that affordable by a peasant in a certain village in Chungu, deep there in Mukono Central Division. So you find that some of these are experiences. Some of you people have to know that there's people down there, when you are drinking this good water here, there are some people in Africa who are really drinking very dirty water. But I have to thank you because, for example, Professor has been bringing so many of you in our communities. You have done a good job, for example, in Reza Primary School, and you're still doing more. We are so much thankful for that. And we encourage more of you to come and share with us, work with us, and see how we can at least, we can't match with you, I understand, but at least how we can best do some things that our communities at least can also get happy for the services. I don't think I have to add more. I have said enough. Thank you so much for listening to me.
Yes. I'm the director of the Global Health Institute. I get to ask the first question, right?
Yeah.
No, okay. Linda, you go. No,
But I'm the chair.
So these are challenging questions, and there are many of them. There are many different challenges, and they're very connected to each other. And yet, many times when we focus on them one at a time, we try to fix something, and we may